For decades, trauma therapy relied heavily on cognitive processing, asking patients to think and talk their way through profound psychological distress. Today, clinical care prioritizes the body first. You must regulate the physical nervous system into synchronized rhythms before the brain can process traumatic memory. This medical illustration displays the vagus nerve, or cranial nerve X, a sprawling biological superhighway descending directly from the brainstem into the heart, lungs, and digestive tract. Operating entirely outside conscious control, it regulates the parasympathetic resting state, controlling everything from heart rate to digestion. In 1994, Dr. Stephen Porges proposed a model for how this nerve governs our sense of safety and danger, publishing the polyvagal theory. The model provided a precise biological language for trauma. It was rapidly adopted across the psychiatric and therapeutic communities, serving as the physiological foundation for widespread treatments like somatic experiencing and the Safe and Sound protocol. Yet outside the clinic, the theory faces intense scrutiny. Within the fields of evolutionary biology and comparative neuroanatomy, polyvagal theory is actively rejected. Researchers argue that the core biological timelines, the neuroanatomical wiring, and the evolutionary history upon which Porges built his theory are demonstrably false. All of this creates a unique scientific paradox. We have to ask how a framework can be so highly effective at treating human trauma in the clinic, while the biology it relies on fails to hold up in the laboratory. This diagram compares the traditional understanding of the autonomic nervous system with the polyvagal model. Historically, biologists viewed the system as a binary toggle, sympathetic, fight or flight, versus parasympathetic, rest and digest. Polyvagal theory replaces that toggle with a phylogenetic ladder consisting of 3 distinct tiers. At the bottom rung sits the dorsal vagal complex. Originating in the dorsal motor nucleus, these fibers are unmyelinated, meaning they conduct signals slowly. Porges identifies this as an ancient reptilian system, responsible for primitive immobilization, metabolic conservation, and the freeze response. Above that is the middle tier, the sympathetic nervous system. This drives active mobilization, accelerating heart rate and preparing the body for active fight or flight. The highest tier is the ventral vagal complex, originating in the nucleus ambiguus. Unlike the lower tier, these fibers are myelinated for rapid signal conduction, acting as a highly sensitive brake on the heart rate. Porges argues this upper circuit physically links with cranial nerves controlling the jaw, face, and larynx. Together, they form a uniquely mammalian social engagement system, regulating facial expressions and vocal tone to signal safety to others. The functional core of polyvagal theory is the concept of dissolution. It posits that when a human experiences acute threat, their nervous system biologically regresses down this exact evolutionary ladder, dropping from social engagement down to sympathetic panic, and finally into a dorsal vagal freeze. This concept of reverse evolutionary regression borrows from 19th century neurologist John Hewlings Jackson, applying his theories of structural brain disease to modern autonomic stress. By mapping behavior to this specific hierarchy, polyvagal theory insists that severe trauma responses, like dissociation or complete immobility, are not cognitive failures. They are predictable biological regressions into older defensive states. To move this evolutionary hierarchy out of the abstract and into patient care, clinicians require observable data. They need to measure exactly which tier of the ladder a patient's nervous system is currently occupying. This chart shows a sine wave plotting heart rate over time, synchronized with breathing cycles. This specific metric is called respiratory sinus arrhythmia, or RSA, and it serves as the primary measurable index of ventral vagal tone. The rhythm exists because a common cardiopulmonary oscillator, located in the brainstem, sends synchronized electrical pulses down the phrenic nerve to the lungs and simultaneously down cardiac vagal fibers to the heart. By analyzing the phase consistency between respiration and heart rate variations, researchers extract advanced metrics known as weighted coherence and vagal efficiency. These numbers reveal exactly how well a patient's ventral vagal system is buffering them against physiological stress. When the nervous system detects danger, a non-conscious process Porges named neuroception, this ventral vagal brake is forced offline, triggering immediate regression down the autonomic ladder. If the system cannot climb back up, vagal efficiency remains chronically low. In the clinic, this specific autonomic disruption correlates heavily with severe functional gastrointestinal disorders, chronic pain syndromes, and persistent dissociation. Treatment protocols like somatic experiencing use this biological map to guide therapy. Practitioners monitor minute physiological shifts, gently titrating trapped survival energy to coax the ventral vagal system back into a dominant regulating position. These biomarkers take the highly subjective, often incommunicable experience of trauma and render it as an observable, quantifiable state of physiology. This clinical success is built on a specific biological axiom. Polyvagal theory asserts that the myelinated ventral vagal complex is an evolutionary innovation entirely unique to mammals, developed specifically to support social behavior. However, evolutionary biologists testing this claim found an immediate glaring contradiction when examining the anatomy of basal air-breathing vertebrates. The timeline breaks when you look at the lungfish, an ancient species that sits at the evolutionary base of air-breathing vertebrates. Dissections of the lungfish reveal myelinated vagus nerve fibers originating from the nucleus ambiguus and connecting to the heart. The circuitry exists here, proving that this neural architecture is not a recent, uniquely mammalian adaptation designed for sociality. This medical illustration details the upper brainstem region. Neuroanatomists analyzing these structures have leveled equally severe critiques at Porges's characterization of the lower tier, the dorsal vagal complex. The theory relies on the premise of direct communication between brainstem branchiomotor nuclei and the visceromotor portion of the nucleus ambiguus. Anatomists note that this wiring does not exist in the human body, leaving the theory's map at odds with the physical communication of the vagal networks. Furthermore, linking the dorsal vagal complex exclusively to a passive defense or freeze response mischaracterizes the broader, highly active role these pathways play in general visceral regulation. Even the biomarkers are contested. Researchers point out that respiratory sinus arrhythmia is heavily influenced by sympathetic arousal, meaning it cannot serve as a pure, isolated measurement of vagal tone. The clinical metrics offer real utility for tracking patient stress. But the strict phylogenetic literalism, the evolutionary timeline, and the precise anatomical wiring dictated by polyvagal theory has been repeatedly falsified by comparative biology. We are left with a collision of disciplines, a theory that stands as a biological mismatch, but functions as a widely successful clinical framework. If we discard the entire framework because of its evolutionary inaccuracies, we strip trauma therapists of a tool that routinely succeeds where traditional talk therapy fails. This diagram models a necessary separation. We can discard the phylogenetic literalism of the model while retaining it as a powerful clinical heuristic. What polyvagal theory got right was its shift in focus. It moved trauma care away from demanding top-down cognitive logic from patients in distress and instead prioritizes bottom-up physiological regulation. The clinical interventions derived from this model, tracking rapid state shifts, grounding patients in their bodies, and using the therapist's own calm presence for co-regulation, remain highly effective. They work regardless of the lungfish, and regardless of the exact evolutionary timeline of myelination. Moving forward, advances in wearable telemetry and real-time tracking of vagal efficiency will continue to refine these treatments. We are replacing abstract evolutionary ladders with objective, real-time data. The model endures because it isolated a profound truth about human recovery. Biological safety in the body is an absolute prerequisite for social engagement and complex thought. Polyvagal theory will not survive as a flawless map of mammalian evolution. It survives as a conceptual shift that recentered the body in the treatment of trauma, moving the focus from the narrative of the event to the physiological state of the survivor.
If this video added value in your life, please like, comment, and share this video, and subscribe to Mind Reprogramming.